Assalamu alaikum everyone. The next topic of discussion is a type of thrombocytopenia known as ITP, immune thrombocytopenia purpura. In this disease, usually antibodies are formed against the platelets, and it is usually common in children, often following a viral illness and usually self-limiting, while in adults, it usually having a chronic course. So it was previously referred as idiopathic thrombocytopenia purpura. However, the term is now outdated. We have primary immune thrombocytopenia. It's an autoimmune disorder characterized by isolated thrombocytopenia. Only platelet count is decreased with no known precipitating cause. In secondary, an autoimmune disorder causing isolated thrombocytopenia, but there is a secondary identifiable trigger present. Now we have newly diagnosed, persistent, and chronic ITP. Newly diagnoses are all the cases that are within the third month of the diagnosis. Persistence are those which last for 3 to 12 months, and those cases which last for greater than 12 months, these are called chronic ITP. It is usually common in female, and in children highest prevalence is below 5 years of age, and is typically a self-limiting disease after a viral infection. So there will be often given a history of viral infection, and a child will present with mild bleeding. So you should consider ITP as a diagnosis. 80% of cases resolve within 1 year of time. Adults, highest prevalence is in individual greater than 55. 80% patient develop chronic, and an incidental finding on a routine CBC in 25% of the cases. What is the underlying etiology? So in primary, the cause is usually unknown, and the primary is the most common type. In secondary, there are underlying triggers present like autoimmune disorders, SLE, antiphospholipid syndrome, malignancies like lymphoma, leukemia, particularly CLL, chronic lymphocytic leukemia, infections like HIV, HCV, and drugs. So drug-induced ITP is due to quinine, beta-lactam antibiotics, carbamazepine, heparin, vaccines, linezolid, sulfonamides, vancomycin, trimethoprim, sulfamethoxazole, and antiepileptics. What is the underlying pathogenesis? So antiplatelet antibody, mostly IgG, are directed against GP2B3A and GP1B9 receptors, which are platelet adhesion receptors, and these antibody bind to the surface protein on the platelets, leads to sequestration by the spleen and liver of the platelets, so the platelets count decrease, leads to bone marrow megakaryocytes and platelet production increase. So bone marrow will respond to this hemolysis. Clinical feature can correlate with platelet count. Most commonly, usually asymptomatic, and remember that splenomegaly is typically absent in ITP. Minor mucocutaneous bleeding is less common, and if present as bruising, petechiae, purpura, and mucosal bleeding like epistaxis and gums bleeding. Other type of bleeding like GI bleeding, genitourinary like hematuria, heavy menstrual bleeding, CNS feature of intracranial hemorrhage, and prolonged or excessive traumatic or surgical bleeding. These presentations are rare. Splenomegaly is very unusual in the ITP and makes other diagnoses more likely. There should be suspicion for ITP in child with thrombocytopenia and petechiae following a viral diagnosis. So ITP is a diagnosis of exclusion. Patients typically have a low platelet with no other abnormalities. So on lab finding, you will have decreased platelet count, usually less than 1 lakh, and coagulation panel is usually normal. Bleeding time prolonged. So bleeding time is prolonged, platelet count decrease, and coagulation panel is usually normal. And smear, there are usually normal to large platelets. Abnormally large or small platelets should give you a hint toward other diagnosis. Additional investigation can be done like HIV and HCV screening, bone marrow biopsy. Consider an atypical cases or if there is diagnostic uncertainty. Findings, so there will be normal or increased megakaryocytes in response to decreased platelet count. The bone marrow will start to produce more platelets. So there will be increased megakaryocytes in the bone marrow. Additional testing is required considering suspected secondary ITP like ANA in SLE or H. pylori test if the patient has GI symptom or is from a high prevalence area. Now treatment. In treatment we have conservative management. What are the indications for the conservative management? One is Child presenting with no symptom or only mild mucocutaneous bleeding with any platelet count. So, for the child, it is usually a self-limiting disease, and for the adults, no symptom or minor mucocutaneous bleeding with a platelet count of greater or equal to 30,000. So, if the platelet count is greater than 30,000 in adults, we do usually conservative management, and for child with any platelet count, we have the option conservative management. First line medical therapy, so preferred is steroids. So first line treatment is steroid, dexamethasone or prednisone, and alternative options are if contraindication or if there is no response or there is intolerance to steroid. So if there are contraindication to steroid, there is no response to steroids or intolerance, we can consider IVIG, IV immunoglobulin, and ROCAMs, which is anti-RHD immunoglobulin. We have subsequent therapeutic options. So, if the patient is refractory to first-line medical therapy or persistent chronic ITP, then we can consider thrombopoietin receptor agonists like romiplastim, altrombopag, rituximab, and splenectomy. Indication for the splenectomy are treatment-resistant thrombocytopenia lasting greater than 12 months and severe bleeding that doesn't respond to any other treatment. What is the procedure? So, minimally invasive laparoscopic procedure is preferred. So for all patients, identify and treat the underlying cause and consider stopping medication that impair platelet functions. For example, NSAIDs. Patient requiring emergency treatment like having life-threatening bleeding, having neurological features, or those who will be undergoing urgent surgery or invasive procedure. So attempt hemostatic control if the bleeding is present and start combination therapy of steroid plus IVIG plus platelet transfusion as needed. If no response, so consider a thrombopoietin receptor agonist, for example, romiplastim. Patient with no symptoms are having only minor mucocutaneous bleeding, so conservative management is preferred. Adult having platelet count greater than 30,000 and child with any platelet count. First line medical therapy is indicated for adult with platelet count less than 30,000. So if the platelet count is greater than 30,000, conservative management, and if the platelet count is decreased or below 30,000, so first line medical therapy is given. And for chronic cases, consider subsequent therapeutic options depending upon individual and patient factors. Patient with significant but non-life threatening mucosal bleeding and the symptoms impacting the quality of life. So, first line medical therapy is considered for adults and can be considered in children as well. Consider subsequent option if refractory to first line medical therapy. So, that's all about immune thrombocytopenia purpura.